All right, so those of you who made it through the first hour, congratulations. This second hour on the knee is going to be talking mostly about ligamentous injury, patterns of injury, and again, it's going to be very heavy on anatomy. The reason I do that in my lectures is because I think that an understanding of the anatomy of any joint is, or anything doing a radiology, especially musculoskeletal radiology, is extremely important. And I think if you understand the anatomy, the pathology becomes much, much easier. I have a hard time remembering a lot of little things, so I have to understand the anatomy first, and then the rest isn't so confusing to me. I'm going to take a little bit of a different approach in dealing with the ligaments than I think customarily is done. I'm not going to start with the ACL and the PCL. I'm going to start with the lateral compartment because I think the lateral compartment is very confusing. I think it's best to get it over with first to kind of approach it. And I think a lot of people have questions and a lot of confusion about posterolateral corner injury. And so I'm actually going to spend a fair amount of time on that. And I hope clear up some questions and that people have about that. So with that introduction, I'd like to get started. Again, starting in the lateral side and moving our way around to the cruciates, and then if we have time to the medial side. There are multiple structures on the lateral side which provide stability to the knee joint. The iliotibial tract is one of those. There's the middle third lateral capsular ligament, which is also known as just the lateral capsular ligament. I'm not going to have a lot to say about that because it's not very important. The oblique popliteal ligament, the lateral gastroc, and then the feared and hated structures of the posterolateral corner. And I'm going to spend a lot of time talking about those. So some of the basic major structures starting, and remember, all this is on the CD, and I am going to review many of these points over and over. So if we look here, most anteriorly, we have the iliotibial band. If we come back to number 2 here, this is the lateral capsular ligament, which is that a thickening of the capsule between the iliotibial band and the fibular collateral ligament, which is this structure here, 3. And I want to point out this very lateral attachment of the fibular collateral ligament to the fibular head. This ligament here, the Fabellofibular Ligament, much more medial attachment and posterior attachment to the fibula. And then the popliteus tendon, which is here, number 5. Okay, let's start with a couple of words about the iliotibial tract. Don't have a lot to say about this. This is composed of 5 different layers. There's a superficial portion and a deep or a capsulo-osseous portion. The superficial portion is the portion that most of us check out quickly on our MRs. This is the portion that attaches to Gerdy's tubercle here. May become torn relatively uncommonly or may undergo degeneration. This was an injury to the iliotibial tract. Here we have a partial tear and a lot of fluid. Not that exciting, not that much to say about it, but just so you know where it is, the most anterior of the structures that you're going to be looking for on your MRs of the knee. The capsulo-osseous portion of the deep portion of the iliotibial tract or band is likely the etiology of the Sagan fracture, and I'm going to have some more to say about that later. Most people probably in this room, and I was taught initially that the lateral capsular ligament was the ligament responsible for the Sagan fracture. That is probably not correct, and is probably a portion of the iliotibial tract and a portion of the actually fibular collateral ligament. More on that later. Iliotibial tract friction syndrome refers to a clinical syndrome of anterolateral knee pain that's commonly seen in runners, cyclists, and patients and people who play contact sports. It is due to friction of the iliotibial band as it passes over the lateral femoral condyle when the knee is flexed. So you can see how runners and cyclists would be prone to such a problem because of the repetitive flexion of the knee in those activities. What you'll see on MR imaging is edema between the iliotibial band and the lateral femoral condyle, or fluid and synovitis in the lateral joint recess. Now, note that the fluid here is really asymmetric. There's not a lot of fluid anywhere else. It's all over here in the lateral recess. The iliotibial tract is thickened. Those are the findings that you're going to see in iliotibial tract friction syndrome. And again, a thickening of the iliotibial band. Here, just another example. Note all this fluid here in the lateral recess anteriorly. It's coming actually too far posterior. And here, note the iliotibial tract here, and also all this stuff. This is synovitis. This is all thickened synovium in that area. That's not normal. That's not just a joint effusion. And note that there's not much fluid in the rest of the joint. There's no fluid over here. It's all over in this area, and there's associated synovitis. The iliotibial tract does not look that thick in this case, but that's compatible with iliotibial tract friction syndrome. Okay, enough about that. This is more interesting, I think, more complicated. The posterolateral corner structures. There are many structures that make up the posterolateral corner. The fibular collateral ligament is one that's obviously very important here. The fabellofibular ligament. This is the fabella here. The fabellofibular ligament is this structure here, coming from the fabella down to the fibula. The popliteofibular ligament, the arcuate ligament, the popliteus tendon, the biceps femoris tendon. All of these structures work together to provide stability to the posterolateral corner of the knee. Okay, and we're going to go through these one by one because I want you to have an understanding of what these structures are and how to diagnose injuries of them. The posterolateral corner structures as a group resist posterior translation, varus angulation, and external rotation of the knee. That's their major function. Okay, starting with one of the easy ones, the fibular collateral ligament. The fibular collateral ligament originates proximal and posterior to the lateral epicondyle of the femur. It inserts onto the lateral aspect of the fibular head. There may be a bursa between the fibular collateral ligament and the biceps femoris. There are some fibers which are not pictured on this diagram. There are some fibers known as the anterior oblique fibers, the anterior oblique band of the fibular collateral ligament, which insert onto the tibia. Those fibers, along with the deep capsulo-osseous portion of the iliotibial band, are the structures that are likely responsible for the Sagand fracture. The biceps femoris tendon, intimately associated with the fibular collateral ligament. It has 4 arms. Not important to know what the arms are, just know that 3 of the arms insert onto the fibula. 1 of the arms inserts onto the tibia, but most of it inserts here onto the fibula. Again, relatively laterally on the fibular head. Okay, so here we see this structure here very nicely. This is the fibular collateral ligament coming from the lateral femoral condyle, inserting on the fibular head. Here we see it there. And then this is the biceps femoris tendon. Here we see it. We're not seeing the whole thing. This is the muscle coming into tendon. And note that they're kind of coming together. They come together and form what's known as the conjoined tendon. The important thing to notice in this picture, and I'm going to emphasize this over and over because this is how you're going to determine which ligaments are injured. But the important thing to remember is that these ligaments insert relatively laterally. Okay, laterally on the fibular head. This is what they look like on your sagittal images, the Playboy bunny ears. Here, the fibular collateral ligament. This is the tendon of the biceps femoris. These come together. They form the bunny ears here, conjoined tendon here, inserting on the lateral aspect of the fibular head. The fabellofibular ligament. Yes, you can see this on your MR images. It's not present in everyone, and you don't always see it, but you can see it in many cases where I have been able to identify it. You just need to know where it goes. It goes from the fabella to the lateral aspect of the fibular styloid process, okay? It inserts a little bit more medial than the fibular collateral ligament and the biceps femoris tendon. So lateral aspect of the fibular styloid process, just anterolateral to the insertion of the popliteofibular ligament, which I'll show you later. But note here, find the fabella. This is the fabella. Here's the fabellofibular ligament extending from the fabella down to the lateral aspect of the styloid process. This is the styloid process of the fibula, this little bump here on top. Lateral aspect of the styloid process. Note it's medial to the insertion of the biceps and the fibular collateral ligament over there. So fabellofibular ligament, very important structure in the posterolateral corner. The arcuate ligament. Everybody hates this ligament because you can't, it's very hard to see, but it is kind of important. And a lot of times we have to infer that there's been injury of this. I'm just going to go over the anatomy so you know the basic area where this is. This is a Y-shaped structure. It's A and A. It has 2 arms, you can see. It comes down and insert here on the fibula. The fibular insertion is on the styloid process just deep to the fabellofibular ligament. Okay, so here, this structure is the fabella. This is the fabellofibular ligament. Just deep to that is the arcuate ligament, okay? It's actually not that complicated. This is the fibular collateral. Deep to that Fabellofibular. Deep to that is the arcuate ligament, okay? There are two limbs, as I said. The lateral limb, which is also known as the upright limb, is this limb here. And then the medial limb, which is also known as the arcuate limb. The medial limb crosses over the popliteus tendon and inserts onto this structure back here, which is actually a continuation of some of the medial structures that comes across and forms part of the knee capsule posteriorly. Okay, so this is the lateral and the medial limbs. Note here popliteus tendon, popliteofibular ligament, the next one we're going to look at. This gives you a nice, shows you very nicely where all the ligaments insert. They just kind of come across from lateral to medial. Here, I think this was from some work done by a resonance group in San Diego. Very nicely shows you all of these ligaments. Fabellofibular ligament. Here's the arcuate ligament. This is the medial limb coming across the popliteus tendon here. And then this is the upright limb or the lateral limb that's coming to insert up here on the femoral condyle. Here's the fibella, lateral head of the gastrocnemius, and the fibular collateral ligament. Okay? This is popliteofibular ligament. If you look very closely here, this is unfortunately not my image. I wish I had some nice images to show you. But these are the two limbs of the arcuate ligament. One is here. This is the other limb here that's being outlined. Those are the limbs of the arcuate ligament. So very hard to see, although occasionally you can see it. So now that we know the anatomy of this area, we look closely at this image. We find the fabellofibular ligament. We know where the arcuate ligament is going to insert, right next to it, and this is it. This is a part of the arcuate ligament. I'm not sure which limb this is. But you see a little bit of the arcuate ligament. So if you know where to look for it, you may actually see it. You can improve if you're suspecting a posterolateral corner injury, you may be able to improve your ability to see these structures by doing oblique coronal images that are along the course of the popliteus tendon, okay? So if you plan oblique coronal images along the axis of the popliteus tendon, that may significantly improve your ability to see these structures. Okay. Finally, let's talk about the popliteal complex. The popliteus tendon itself inserts into a sulcus in the lateral femoral condyle, deep to the fibular collateral ligament. The medial limb of the arcuate ligament forms the roof of the popliteal hiatus. We talked about that. The popliteofibular ligament comes from the myotendinous junction of the popliteus and inserts on the fibular styloid, medial and posterior to the arcuate and the fabellofibular ligaments. Okay, that's a lot of words. All right, so what are we looking for, actually? We're going to look for this. This is the popliteus tendon, okay? You can actually see the structure. All these structures, I think back here, you can find if you're looking for them and know where to look, except the arcuate, I think, is very, very difficult. This is the popliteus tendon, okay? If you see something coming off at about 90 degrees from the popliteus tendon heading down toward the fibular styloid, that's the popliteofibular ligament. I have it outlined here with the red arrows. Note the insertion. Fibular styloid process right here, medial to the fabellofibular, arcuate, and fibular collateral ligament. So it's medial over here, kind of sits right up there on the fibular styloid process. I think it's actually not that, depending on your resolution and your magnet and your protocols, it can be seen. And it always looks like it comes off at almost at like 90 degrees to the popliteus tendon and comes right down here to the styloid process. Very important ligament. Okay, so let's review what we talked about. Biceps femoris tendon number 1 here. Number 2, fibular collateral ligament. These are kind of coming together, inserting laterally on the fibular head. Popliteofibular ligament right here, much more medial onto the styloid process. Note that it's coming off, maybe not quite 90 degrees, maybe a little less than 90 degrees. But note that it's coming right off here, right off of the popliteus tendon to insert onto the styloid process of the fibula. Okay, this is a diagram I think is great. This is from work done by Don Resnick's group in San Diego, and it's nice because it shows you schematically where all of these ligaments are supposed to attach. Lateral collateral, which is the same thing as what I'm calling the fibular collateral ligament, and the biceps femoris tendon. That's the direct arm. But anyway, the biceps femoris tendon and the fibular collateral inserting out here, way out lateral, okay? You come across a little bit more medially up to the styloid process, and what do we have first, the fabellofibular and the arcuate ligaments. They insert near one another right here on the lateral aspect, the styloid process. And then as you come most medial, that's the popliteal ligament inserting here on the styloid process medially. Okay? Here, this is an axial schematic. And you got your fibular collateral ligament. Then up here on the styloid process, we have the fabellofibular and the arcuate ligaments, and then most medially over here, the popliteofibular ligament. Okay, it's all in your CD. Posterolateral corner injury. This can be very difficult to diagnose, but I think now that you have some understanding of the anatomy in this area, it's going to make it easier to diagnose. The major structures preventing posterolateral instability are the fibular collateral ligament and the popliteus tendon, with the popliteofibular ligament providing some static stability to the posterolateral corner. Injury to these structures occurs from a direct blow to an extended knee with an anteromedially directed force to the tibia while the tibia is externally rotated. When all that happens, this is what you get, okay? This is injury to the posterolateral corner. In this case, note where the avulsion fragment is. This is from the lateral aspect of the fibular head. This is from the insertion of the fibular collateral ligament and the biceps femoris tendon. Okay, this is what injury to those structures looks like. This is not injury to those smaller structures of the fabellofibular and arcuate ligaments. Okay, typical appearance: fibular collateral and biceps femoris injury. Okay, conjoint tendon. Posterolateral corner injuries can be very difficult to detect acutely because there's a lot of edema and hemorrhage in this area. They are important to detect because they result in posterolateral instability of the knee. What is that? Well, that's posterior subluxation, varus angulation, and external rotation of the tibia relative to the femur. Very important to diagnose these injuries. These need to be repaired. If they're not treated, these injuries are often associated with ACL and PCL injuries as well. If these injuries are not repaired or not treated, and the patient does go on to have ACL or PCL repair, the ACL or PCL repair will likely fail because of the posterolateral instability that has not been addressed, and so the ACL repair will often go on to fail. Here are your bunny ears, your Playboy bunny ears: fibular collateral ligament, biceps femoris tendon coming down, and what are they inserting onto? This piece of bone that's been avulsed from the fibular head. This is not so tough. This is not so bad when these structures are injured. They're pretty big structures. Everybody looks for these every time you have a knee MR. It's the other ones that are a little bit more complicated, and they're easier to walk by. The arcuate sign. Okay, there's a lot of confusion. There's confusion in the literature, I think, about this, about what really the arcuate sign is. Okay, the arcuate sign is a avulsion of a small fragment of bone from the fibular styloid process, not from the lateral margin of the fibula where I showed you where I showed the fibular collateral and biceps inserting. Okay, not what I showed you before. This is the arcuate sign at the apex of the styloid process. This reflects injury to the fabellofibular, arcuate, and or popliteofibular ligaments, okay? Because you know from our review of anatomy, that's where those ligaments insert, on the styloid process, not way over here where the biceps and the fibular collateral insert. Produces an elliptical fragment of bone that we see here. And this is what it looks like. This is the arcuate sign, okay? So on radiographs, you can see this. And I love to try to kind of look for this on radiographs in trauma patients to see if we can prospectively diagnose posterolateral corner injury. Here we know a big effusion. Patients had acute trauma. And if you look closely here, see this little fragment of bone from the fibular styloid process. Arcuate sign. This is a radiographic sign of a posterolateral corner injury. Here confirmed on CT, small fragment of bone from the styloid process of the fibula. Same patient. Hard to see here, but here, what do we see? A lot of edema in the fibula. This is the small fragment of bone. But look at this. The ligaments coming over here are relatively intact. It's the ligaments attaching to the styloid process, the arcuate, the fabellofibular, and the popliteofibular ligaments. Can you imagine those ligaments coming right across there that I showed you before? Here's the popliteus. Those ligaments coming right to insert on that area where that piece of bone has been avulsed. Okay, another example. Look here, this is the biceps coming down to insert. Notice where it inserts, over here laterally on the fibular head. Not disrupted, completely intact, looks fine. And what do we have here? What ligament? This is the popliteofibular ligament. You can see it's wavy, should be coming down to insert, should be coming straight off like that to insert right there on the styloid process. It's torn. Popliteofibular ligament is torn. That's what posterolateral corner injury looks like, okay? Opposed to when you have injury to the fibular, collateral, and biceps, is usually a lot more obvious. Remember, as I said again, lateral margin of the fibular head, much easier to assess on MR. Here we see it. Fibular collateral ligament following, oops, gone, piece of bone here from the lateral margin of the fibular head. Conjoint tendon has been disrupted, probably injury to the popliteus muscle as well. Much easier to diagnose. So here you see, same thing, much easier to diagnose these injuries because the ligaments are much larger. Same thing here. Much easier to diagnose these injuries. Here's a fibular collateral ligament. The biceps is intact, but the FCL is disrupted. This is all the torn, retracted fibers from back here and over here. So a little bit of a different variation on the same theme. You trace your ligaments down here, they look okay. But if you look up proximally, relatively uncommon proximal avulsion of the fibular collateral ligament. As I mentioned, there are multiple associated injuries with posterolateral corner injury. The ACL is commonly injured in association with posterolateral corner injury. Here again we see the same kind of thing. PCL commonly injured, MCL, meniscal tears, contusions in the tibia and the femur, and especially contusions of the medial femoral condyle. So here we can see, now we know we have the Arcuate Sign, we know we have a posterolateral corner injury, associated ACL tear. Here we have a different patient, I believe. Note the edema here in the styloid process of the fibula. Again, we know what's inserting there now. ACL, associated ACL tear and PCL tear. Incomplete probably, but markedly thickened heterogeneous PCL. ACL also torn. Bone bruise in the medial femoral condyle, commonly associated with posterolateral corner injury. Popliteus muscle, this is all the same patient. Popliteus muscle also severely strained. Popliteus muscle, meniscal contusion. Okay. Meniscal contusions usually defined as a meniscus within a meniscus appearance, or extensive abnormal intrameniscal signal in the setting of trauma. The signal usually doesn't go to the articular surface and it will get better over time. This could be a meniscal tear. I don't know if it was a tear or contusion. The other sign, this is to answer someone who's asking me about fluid. You see posterolaterally in the knee. If you see, this is the popliteus tendon. If you see edema or fluid superficial to the popliteus tendon, again, we know the anatomy of this area now. If we see fluid or edema superficial to that tendon, that finding is highly suggestive of posterolateral corner injury. Okay, you should not have edema in that area, superficial popliteus. For those of you who were here for the last lecture, I talked about the loose attachment between the lateral meniscus and the capsule, and that's so it's often you often do see fluid in this area, deep to the popliteus, where those struts or fascicles are. There's often fluid in that area, but there should not be fluid superficial to the popliteus. If you see it, you need to suggest posterolateral corner injury. Again, here, styloid process avulsion. Typical appearance of posterolateral corner injury. If you see the other injury on here, the associated injury, PCL is torn. Okay, so that's all I have to say about posterolateral corner injury. I hope that cleared up some of the questions and concerns about that area. And if you have questions later, I'll be happy to answer them. I'd like to move on now and talk about the cruciates, and then hopefully some words about the medial supporting structures. The cruciate ligaments are intra-articular and extrasynovial structures. There are anteromedial and posterolateral bands of the ACL which are named by or according to their insertion on the tibia. As you can see here in this schematic, the bundles twist with motion. So as the knee is flexed, the bundles of the anterior cruciate ligament twist. The ACL is much weaker than the PCL, and the femoral insertion is weaker than the tibial insertion. A gross specimen demonstrates here the anterior cruciate ligament. Here you can see it coming from posterior, starting on the anterior aspect of the tibia. Here you can see the footprint that is left by the ACL, and the two bundles, the anteromedial and the posterolateral bundles. So here's posterior and anterior. Oops, sorry. The anterior cruciate ligament is a primary restraint to anterior translation of the tibia. It also functions as a secondary restraint to tibial rotation, especially as a restraint to internal rotation of the tibia. It's the most commonly injured ligament in the knee. And common sports in which it's injured are skiing and football. The injury is often involves a deceleration and hyperextension of the knee. There's external rotation of the tibia as well as flexion of the knee and a valgus force. It can be a complicated mechanism. We'll go over a little bit more of the mechanism later and show you how you get some of the associated injuries. Most ACL tears occur in the mid-substance of the ACL, as we see here. About 20% occur at the femoral insertion and only about 10% occur at the tibial insertion. MR is very sensitive and specific for ACL injury, and it also allows diagnosis of associated injuries. Remember, the orthopedic surgeons, for the most part, don't really need us to diagnose ACL injury, okay? They can diagnose that on their own. They can make the clinical diagnosis of the ACL being torn. What they want from us when they send the patient with ACL, a prescription that says ACL tears, to tell them what else is going on in that knee. Is there a meniscal tear? Is there a fracture? What other things have happened? Because we're not giving them a lot of information when we tell them the ACL is torn. They already know that, okay, in most cases. Imaging with 10 degrees of flexion of the knee may help separate the ACL from the adjacent cortex. It may make it a little easier to see. There are all sorts of different things you can do, but I think for the most part on modern MR scanners it's pretty easy to see the ACL in most cases. Diagnosis, ACL injury is diagnosed when there's abnormal morphology of the ACL, abnormalities in associated structures and other structures, and if you know the pattern of injury, then you can make the diagnosis or at least look more critically at the ACL. Osseous and osteochondral abnormalities may be associated with ACL injury as well as anterior translation of the tibia. Here we have some buckling of the patellar tendon, which is a secondary sign. I don't think you really need that secondary sign. Here you can see the ACL is torn. And again, this is a typical appearance. I'm just going to show you a couple of examples. Typical appearance. I think most people here know what a typical ACL tear looks like. Here we can see the fibers are disrupted and wavy. There's fluid where the fibers shouldn't be, or where the fibers should be. Here the same thing. And I don't think this is the more interesting part of the ACL injury. Here we see the ACL just kind of lying down in the intercondylar notch. This can simulate a bucket handle tear because of one of the menisci of the because it may look like a meniscal fragment, but if you look closely, you'll notice that there's no ACL, and this is just the ACL kind of sitting down there in the intercondylar notch. What's more interesting is the cases that where there is associated injury in the knee. What other things can we look for, and what other things should we look for when we suspect an ACL injury? One thing is anterior translation of the tibia, more than 5 millimeters. I like to measure that at the level of the origin of the lateral head of the gastrocnemius. I think that's probably the best place to measure that. If you see anterior if you drop a vertical line down, there's more than 5 millimeters of anterior translation. That finding is very suggestive of a ACL tear. It's considered the MR drawer sign. Yeah.
Can you just demonstrate that again? Because I frequently
Oh.
figure that out. Exactly how do you do that?
Oh, what you do, I'm not, see, this is probably not the best image. I'll see if I have a better image, but I find the image where I best see the origin of the lateral head of the gastrocnemius muscle, and all you do is you just drop a vertical line down, okay, and then when you drop that vertical line, you measure the distance from that line to the posterior tibia, and this is not the right image to do it on, because you don't see the lateral head of the gastroc, but if that distance is more than 5 millimeters, that's suggestive, okay? Uncovering of the lateral meniscus. This is a nice example of uncovering of the lateral meniscus. The lateral meniscus is just sitting out here in the breeze, not covered by the tibia. That's because the tibia is anteriorly translated. And here the buckling of the patellar tendon. This is the normal appearance of the posterior cruciate ligament. You should not normally see, I don't think this is a great sign, but it's reported in the literature, so I mention it. But you should normally not see the PCL on a single coronal image. You should see it on, usually see it on two sequential coronal images. This is the normally what you should see. Here we see the distal portion. We don't see much of the proximal. Here we see more of the proximal portion. Here we see the PCL on a single coronal image. That's because of the translation of the tibia, and that finding is associated with ACL injury. I don't think it's a great sign. This sign, if you draw a line along the posterior portion of the PCL, that line should intersect the distal femur. If that line that you draw along the posterior margin of the PCL does not intersect the distal femur, that means you have buckling of the PCL, and buckling of the PCL is a secondary sign of ACL injury. All right, these injuries are more interesting, and I think are also more important to recognize when you're suspecting or you know you have an ACL injury. Sagan fractures, excellent radiographic clue to the presence of ACL injury. Bone contusions, the deep sulcus sign. Tibial avulsion of the ACL insertion, like we see here, that's most commonly seen in children. Here's a Sagan. Posteromedial tibial plateau injury, and semimembranosus avulsion fractures. Sagan fractures, highly associated with ACL tear, is also very highly associated with meniscal tear. So if you see a Sagan fracture, you certainly got to suggest there's an ACL tear, but you should also suggest an underlying meniscal tear as well. There's also a high association between Sagan fractures and posterolateral corner injury. The presence of a Sagan fracture is compatible with anterolateral rotatory instability, which is anterior translation and internal rotation of the tibia relative to the femur until proven otherwise. It can be very difficult to see, as in this case. You know, it's very tough to see. You need to check every x-ray for this. Avulsion of a small fragment of bone from the lateral margin of the tibial plateau. Well, how do these occur? They were traditionally thought to be due to avulsion of the middle third lateral capsular ligament. And I talked about that at the very beginning. That's a capsular thickening between the iliotibial band and the fibular collateral ligament. Okay, this ligament, the LCL, lateral capsular ligament, is small and thin, probably not capable of avulsing any bone to begin with. So Don Resnick's group did a really nice study out in San Diego and looked at the at these fractures, and they found that the capsulo-osseous portion of the iliotibial band, which is the deep layer of the iliotibial band, and the anterooblique bundle of the fibular collateral ligament, which is a tibial insertion of the fibular collateral ligament, likely play the major role in the pathogenesis of the Sagan fracture. Okay, now this is kind of a busy slide. And I'm not sure it's from their article or not, but here's the fibular collateral ligament. Most of it's going to come down to insert on the fibula here, but this is a portion of it. This AOB, that's the anterooblique bundle or band of the fibular collateral ligament. And if you notice, it's coming to insert here on the tibia. This is the iliotibial band or tract. Okay, this has some the deep fibers. They're inserting in this area, and those are the ones that are likely responsible for the Sagan fracture, not this little piddly ligament in here, the lateral capsular ligament. All right. Okay, this is what Sagan fractures look like on MR. They can be very tough on MR to see, actually. Remember that avulsion fractures tend to produce less edema in bone than do compressive type fractures. So avulsion fractures may have very, very little associated edema. You may not see much. This is the piece of bone, this little flake of bone over here, that's the Sagan fracture. Very little edema. There's a lot of edema in the soft tissues, but not really a lot in the underlying bone. Here's the small fragment of bone. That's the Sagan fracture right there. So you need to have a high index of suspicion, because these can be pretty tough to see. This is a patient who had a Sagan fracture. Here, a skeletally immature patient. Sagan fracture, had an ACL injury. Here you see the fragment. He went on to have ACL reconstruction. And here we see this. This is what's known as a Bosch-Bach bump. This is a Sagan fracture that has reannealed or healed back to the tibial plateau, and is just a little bump of bone. But this is what an old Sagan fracture looks like. So I just wanted to show you one example of that. That's what it looks like once it's healed back. Okay, this is, I think, another interesting sign. Unfortunately, I don't have a good example myself of this, but I wanted to show it because I think it's a nice example. And I mentioned it earlier. This is semimembranosus avulsion fracture. Okay, this is a fragment of bone that's been avulsed from the posteromedial aspect of the tibial plateau in the region of the insertion of the semimembranosus tendon. Okay, so now some people hopefully will say, well, how do you know this isn't a PCL avulsion? Because PCL avulsions look relatively similar. They occur back in the same area. Well, what you want to look for is what's called the 7 sign. There we go. That's the 7. The 7 is formed by the posterior aspect of the tibial eminences and the posterior aspect of the intercondylar notch here in the tibia. Okay, this is the 7. If that 7 is not interrupted, then you probably do not have an avulsion. You don't have an avulsion of the PCL. These semimembranosus avulsion fractures do not avulse do not interrupt this 7 created by the posterior margin of the tibial eminences here and the posterior aspect of the tibia. I'm going to go back so you can see what it looks like without the line on it. But that was the 7 sign. On MR, you can see this is the semimembranosus tendon. This is the insertion onto the medial tibial plateau. This particular type of fracture highly associated with ACL injury, so a plain film radiographic finding of ACL injury in addition to the Sagan fracture. Okay. The pattern of bone contusions you see with ACL injury can be variable. The ones that are relatively constant are the ones that occur on the posterolateral aspect of the tibia and on the lateral femoral condyle, and they occur in a relatively characteristic location. There's a third bone bruise that may occur, which is in the posteromedial tibial plateau. This is a contracute impaction injury. It's a little, it's not always seen, but you see it a fair amount, and I'll show you an example of that. There is a high association between patients who have this type of posteromedial tibial bone bruise and an ACL tear with peripheral meniscal tears or meniscocapsular junction contusions or separations. Okay, so this patient demonstrates the typical findings that we're going to see. We can already tell that the ACL is torn in this patient without even seeing the ACL, okay? First thing is, for those of you who were here last time, there's lateral meniscocapsular junction separation or tear. The struts are torn here, okay? So we talked about medial meniscocapsular junction injury, and I showed you lateral as well. This is another example. Lateral injury, the struts are both torn. Then we have the typical kissing contusions here, in the central portion of the lateral femoral condyle, posterior aspect of the tibial plateau. We probably have a popliteus injury as well, but I can't exactly tell. It looks like we do have a popliteus injury as well. Okay, the normal appearance of the posterior margin of the tibial plateau is this. It goes from being relatively convex to being flat. I apologize. Convex, like pooching out, to being flat. Okay, this is not normal. Okay, this concavity in the posterior margin of the lateral femoral condyle is not normal. This is an osteochondral impaction fracture that occurred at the time of ACL injury. Those of you who don't believe me, this is the same patient on the fluid-sensitive sequence. Here's your bruise in the lateral femoral condyle, mid-portion. This is that osteochondral impaction injury posteriorly. Here you have a strut tear. Okay, so what happens with ACL injury? Pattern of injury. So this is normal. Okay, let's just assume for the purposes of this discussion that the tibia stays in one place. That's not actually what happens, but let's just assume. First thing you have is external rotation of the femur then relative to the tibia, okay? This is just for the purposes of this discussion to explain the bone bruise pattern. When that happens, the mid portion of the lateral femoral condyle impacts the posterior margin of the lateral tibial plateau. So those are what they're classically known as the kissing contusions, and that's where they occur. Now, as the femur rotates back, remember we're keeping the tibia constant, as the femur rotates back, what you get is the contracute injury. And this contracute injury occurs on the posterior aspect of the medial tibial plateau over here, and then the knee comes back into normal anatomic alignment. And what you're left with are your contusions here laterally that everyone knows, plus your contusion here on the posteromedial aspect of the tibial plateau. Okay, so let's go through a case. Here we see contusion here, lateral femoral condyle, posterior lateral tibial plateau. We've got a meniscal tear, ACL tear. We've got our contusions, and look over here medially. The Contusions injury, very, very characteristic of ACL tear. Okay, here if we look on the axial images, we can see we've got the lateral tibial plateau contusion, and then we have the medial tibial plateau contusion here as well. Okay, typical appearance. This is the Contusions injury of ACL. I love this sign. I think it's a great sign. It's great to torture the residents with because they never pay attention to it. But this is a great sign. It probably, I think it's maybe see it more than Sagan fracture. It's a great sign of ACL tear on plain film. This is the osteochondral impaction fracture of the sulcus terminalis, which is also known as the condylopatellar sulcus. It occurs on the lateral femoral condyle. Normally there is a sulcus here, the sulcus terminalis. It's normally less than 1 to 1.5 millimeters in depth. That is if you draw a line tangent across here and measure the depth of this. If the sulcus is deepened to more than 1.5 to 2 millimeters, that finding is highly suggestive of an ACL tear. If you don't believe me, here, nice deep notch sign on MR. I didn't have the corresponding radiograph here. You can see the osteochondral impaction fracture and the associated ACL tear. Note your fracture here on the posterior aspect of the lateral tibial plateau as well. Tibial avulsion fractures, they occur at the anterior tibial eminence at the site of insertion of the ACL. They're more common in children and adolescents than they are in adults. These fracture fragments may invert, so sometimes the fragment will be pulled up and then flipped over. And they may entrap the anterior transverse meniscal ligament, especially if they get displaced anteriorly. Partial ACL tears. This is a difficult area, and this is where the orthopedic, we may play some role in helping the orthopedic surgeon if there's a concern about ACL tear, but their clinical exam is equivocal. ACL tear, partial tears may demonstrate instability, even though the ACL is not completely torn, but the degree of instability on physical exam will be less than that seen with a complete tear. Treatment of these is according to the stability of the knee on the clinical exam. We are not great at looking for partial ACL tears on MR, but I will tell you what you should look for. That is abnormal signal in the ACL, bowing of the ACL, and partial discontinuity of some of the fibers. So this we thought was probably a partial tear. There was other evidence of acute injury here. There's an extensive abnormal signal in the ACL. So you want to see other signs that there has been an injury here, like this contusion here, the medial femoral condyle. Here we see this abnormal signal in the substance of the anterior cruciate ligament. Those findings in the setting of an acute trauma compatible with a partial ACL injury. Here we can see this edema and abnormal signal intensity here in the substance of the ACL. So they can be very difficult to diagnose, and we don't know for sure because the patients are often treated conservatively if they are stable. Ganglia in the ACL are somewhat controversial. People argue about the causes, whether it's due to mucinous degeneration or possibly synovial herniation through the joint capsule or sheath into the ACL. Some people think that they're related to prior partial injury, like a prior partial tear, but it is a little bit controversial, and I don't think any one of these is necessarily the right answer, or I can't tell you, at least at this point, what the right answer is. They're not typically associated with instability or any clinical symptoms, but they are often associated with cysts in the tibia and in the femur. Here's an example of a small ganglion here in the proximal portion of the ACL. This patient had a larger intraligamentous ganglion here, or synovial cyst. Here we see filling up the ACL. But again, they typically are not symptomatic. ACL tears are commonly associated with meniscal tears. Lateral meniscal tears are commonly associated with acute ACL injury, and medial meniscal tears are most commonly associated with chronic ACL injury. If you remember from those of you who here in the previous lecture, double vertical tears are commonly associated with chronic ACL tear. Okay, so here you can see the ACL tear and the associated meniscal tear. O'Donoghue's triad refers to the three entities of a complete ACL tear, a complete MCL tear, and a peripheral tear of the medial meniscus. And here's an example. Here we have our complete ACL tear, the peripheral medial meniscal tear, and the MCL tear. So that is O'Donoghue's triad, if you heard people refer to that. ACL reconstruction, two possible ways to reconstruct the ACL that are commonly used. One is the bone patellar bone graft, and the other is the hamstring graft. The goal of ACL reconstruction is to produce isometry of the ligament throughout the range of flexion and extension of the knee. Postoperative signal changes in the patellar tendon are commonly seen, as well as some ill definition and thickening. That should disappear by about a year to a year and a half postoperatively. So you should not see a lot of abnormalities. And what you should see after that is this. This is what a normal appearance about a year, year and a half after ACL reconstruction with the bone patellar tendon bone graft. And here we just see this defect in the patellar tendon. We see the rest of the patellar tendon on both sides there, no abnormal signal. That's the normal appearance. And here is the graft in place, normal appearance of the graft, interference screws normally placed, the tunnels look good, no evidence of disruption of the graft. So that's what you want to see. Fortunately, that's not always what we see. This is a hamstring graft, somewhat less commonly used, probably has a little bit less associated morbidity. Patients tend to recuperate maybe a little bit faster with the hamstring graft, but then it has to have to be two different incisions, and some people are less comfortable doing this particular procedure. They usually double up the hamstring graft when they take it out. So what you end up with is a little bit different looking graft than you see with a bone patellar bone graft. What you see is a more of a striated appearance. That's not abnormal, and that's okay. They tend not to look as nice and homogeneously low signal as you see with a bone patellar bone graft. They tend to have more of a striated appearance when they use a hamstring graft, but that's okay. So once you've seen what they look like, you won't be fooled on a thing there's something wrong. So how do you evaluate these? I think these are kind of tough, and I'm always asking for consults from my colleagues on these because I think they can be a little bit difficult, but there are some rules that you can follow to help you evaluate these. Where should the femoral tunnel be? The femoral tunnel should be at the intersection of the posterior femoral cortex and the posterior physeal scar. Okay? If you place the femoral tunnel too anteriorly, you're going to have elongation of the graft and lead to instability. So just imagine if you move this tunnel anteriorly, you can see that the graft is going to become all kind of floppy and it's not going to be doing its job. Okay? So this is a good position of the femoral tunnel. That's a normal position. On the coronal images, if you make this into a clock face, the femoral tunnel should be at about the 11 o'clock position and about on the right side, and about the 1 o'clock position if this were the left knee. This is the right knee, and it's about the 11 o'clock position. So that looks good. Here you can see a nice normal appearing ACL graft. The tibial tunnel. This one is one that tends to cause more problems. We see more problems with this. It should be parallel and posterior to an extension of Blumensaat's line. Blumensaat's line is a radiographic projection, which is the roof of the intercondylar fossa. This is Blumensaat's line here, and I've just extended it down, okay? That's what, and a lot of times I'll just take my distance marker on the PAC station and draw it down and just quickly check. That's the normal position. It should be a little bit posterior to this extension of Blumensaat's line. The tibial tunnel should open onto the intercondylar eminences on the coronal images. If the tibial tunnel is placed too far anteriorly, and this does happen, then that causes graft impingement. Because you imagine, if you move this tibial tunnel all the way up here, you can see that the graft is going to be becoming impinged here on the roof of the intercondylar fossa. Okay? Note here that the tibial tunnel opens onto the intercondylar notches. Okay. How do we diagnose graft disruption? What does a normal graft look like? Well, the graft should normally demonstrate low signal intensity. Well, that's nice if we see that. Sometimes, though, it may demonstrate some intermediate signal on T1 and T2 because of some vascularized periligamentous tissue or graft revascularization. But the other thing to remember is that graft impingement may cause this abnormal signal in the graft as well. So you need to look at this and examine it critically. Disruption of the graft leads to fluid signal intensity in the graft, or absolute complete disruption of the graft. And here we have a complete disruption of the graft. We don't have any normal appearing fibers in the region of the ACL here. Okay, this is graft disruption. That's what you don't want to see postoperatively. Here again, let's see, this was a disruption of the graft as well. We don't see the interference screws, but we have disruption of the graft. Extension lag or extension loss is a complication of ACL reconstruction. This is not something you want to have happen. It refers to the inability of the patient to fully extend the knee. And you think that, well, that's not going to be that much of a problem, but such as getting up from a chair or getting up from a sitting position can be very difficult if there's significant extension lag or extension loss. It can be due to several causes. One is graft impingement due to too anterior a placement of the tibial tunnel. If that's the case and the graft is becoming impinged by bone or something here, then you can do what's called a notchplasty, and you can remove the bone that is impinging on the graft. Localized arthrofibrosis, which we mentioned in the last lecture, which is also known as a Cyclops lesion. That's a lesion of fibrous tissue in this area. Can also cause extension lag or extension loss, but that's not going to be immediately postoperatively. It may be difficult clinically to distinguish between graft impingement and the arthrofibrosis, and that's where we may be asked to evaluate the patient. Okay, so here in this patient, if you look, there's a problem here with the graft. The graft is being impinged by this osteophyte here and by this bone here, okay? That's causing impingement on this graft in that area. That's the cause of the patient's problems. There's abnormal signal in the graft. The graft is not discontinuous at this point. It's not disrupted, but there's abnormal signal in it. It's being impinged by this bone in this area, and this needs to be corrected with a notchplasty. Okay. Here again, we have fluid in the substance of the graft. This is a near complete graft disruption here. We have maybe a few fibers. Posteriorly, we see of the graft, but the majority of the graft has become disrupted. Cyclops lesion, here we can see the ACL reconstruction. This low signal intensity lesion here, this is a localized arthrofibrosis that occurs sometimes in the joint, and this again can cause extension lag or extension loss. So another potential cause of extension lag or loss. So two major potential causes can be distinguished on MR. This is another example. I think I showed this in the last lecture. Cyclops lesion, another different patient with a Cyclops lesion, normal ACL graft in this case, and a meniscal re-tear. So in the last 5 minutes, I'm going to spend talking about the PCL. We won't have time to talk about the medial structures. The PCL, like the ACL, is intracapsular and extrasynovial. It is composed of an anterolateral band, which is tense in flexion, and a posteromedial band, which is tense in extension. There are also a few oblique fibers. This is a posterior view, which may simulate the ligament of Risberg. So if you remember, anterolateral band is tense in flexion, posteromedial tense in extension. This is the footprint left by the posterior cruciate ligament, posteromedial band over here, anterolateral. Okay, now as you go through this movie here, you're going to see the bands kind of change color a little bit. The whiter the band, the more tense it is. So as you can see, as there's flexion, the anterolateral band is going to become more tense. And then as the knee comes back to extension, if you look at the posteromedial band here, that's going to become more tense. So the two bands of the posterior cruciate ligament. Remember, the posterior cruciate ligament is much stronger than the ACL. On MR images, it looks very low signal intensity, black in appearance here on the gross specimen, and on a coronal images, very easily seen. But this nice low signal intensity structure, very easy to see on MR. It accounts for less than 20% of ligament injuries, commonly injured in what they call the dashboard type of injury, where the knee is flexed and there's a posteriorly directed force or a fall on a flexed knee. Multiple different potential etiologies of injury. Proximal and distal injuries of the PCL are easy to repair. However, mid-substance injuries are difficult to repair. Unfortunately, most injuries to the PCL are mid-substance, so they can be difficult to repair. Again, a mid-substance injury. Here we see fluid in the substance of the posterior cruciate ligament. Not very hard to diagnose these, but I do want to go over a couple of associated findings that you should look for when you see a PCL injury. Commonly associated with meniscal injuries and with ligamentous injuries, as well as bone contusions. Avulsions of the tibial insertion, I mentioned before. There'll be interruption of that 7 sign formed by the posterior aspect of the tibial eminences and the posterior aspect of the proximal tibia. The reverse Sagand fracture is associated with PCL injury. And remember that if there is associated capsular rupture with a PCL injury or with any ligamentous injury, ACL injury, PCL injury, if there's an associated capsular rupture, you may not have a joint effusion, because if the capsule is ruptured, all the fluid may leak out, and you may not have a joint effusion. A typical appearance of PCL injury. This is the reverse Sagand fracture. I really like this fracture, so I did want to get a chance to show this to you guys. This is avulsion of the tibial attachment of the deep layer of the MCL. I mentioned the deep layer of the MCL in the last lecture. This is where the coronary ligament inserts down here, or the meniscotibial extension of the medial meniscus. If you see this type of fracture, this indicates severe injury to the superficial and deep components of the medial collateral ligament. It's often associated with knee dislocation, and it's commonly associated with a triad of PCL, posterior horn medial meniscus, and MCL tears. Okay, so this is what it is. What it looks like, it's a small fragment of bone, small fragment of bone where that white arrow is, at the insertion of the coronary ligament on the tibial plateau, and here note the PCL avulsion injury. This is another example we had not too long ago, demonstrating a reverse Sagand fracture, small little avulsion fracture. Wouldn't think it's much, but this is a sign of very severe injury to the knee. And here you can see it just kind of blown up, avulsion by the deep layer of the PCL, of the deep layer of the MCL, excuse me. Same thing here, different patient who has a reverse Sagand fracture, little piece, bone avulsed here. Remember, the deep layer of the MCL coming down to insert there. Here we see the normal menisco-femoral extension of the deep layer of the MCL, but the disrupted coronary ligament and that avulsion of that small piece of bone.